Welcome, everyone. We're going to get started. I apologize for the delay. We were having our SoCal Gastro meeting, and we thought we were going to start earlier, but now we're just starting exactly back on schedule. So hope you enjoyed your lunch in the product theater. After lunch, now we're going to talk about weight loss and advanced endoscopy, but then we'll talk about weight loss again. So it's really a pleasure for me to introduce the next two speakers. We're going to start with Dr. Rabindra Watson, and we're going to go through advanced endoscopy abstracts for the next two sessions. And then we'll have a state-of-the-art lecture from Dr. Thacker. Dr. Rabindra Watson is a director of metabolic health program at Cedars-Sinai. Dr. Watson has expertise in interventional endoscopic procedures and bariatric endoscopy, and he's coming back, or he is back in Southern California, so we love having him back here. And I think you've spoken here before, so without any further ado, Dr. Rabindra Watson.
All right, thanks Eric and Gareth and the meeting organizers for the opportunity to talk. I may have met some of you when I was down in LA before, so I was on faculty at UCLA under Eric's guidance for about 6 years, and then went up north to Cal Pacific and UCSF for 4, and now I'm back at Cedars. I couldn't stay away from LA. So I'm going to talk about advanced endoscopy abstracts. These are my disclosures. I put this slide up, kid in a candy shop, because when you're trying to pick the abstracts to talk about, it's just like there's so many that are so interesting, but we're going to try and distill it down. So I'm going to cover the topics of bariatric endoscopy, resection, and then third space endoscopy. So first are our bariatric endoscopy abstracts. Before we get into the abstracts, a paper was just released in Endoscopy that I wanted to bring to your attention. This is a combined document from the ASG as well as the ESG on best practices in bariatric endoscopy. So the reference is up there, published in Endoscopy last month. So check that out when you have time. All right, so our first abstract, can you play the video in the back? So our first abstract is a multi-center pilot randomized controlled trial evaluating the efficacy of the POSE procedure 2.0 in obesity management. So this is a device known as the incisionless operating platform. It's been around for some time now. They had a pivotal FDA trial a little while ago, the Essential trial. They did not meet endpoints. And so they sort of recrafted the procedure, and they call it sort of a belt and suspenders type of approach, but in terms of decreasing the diameter of the stomach and shortening it. And so we're calling this now POSE 2.0. And the device is from USGI Medical. And that's just a quick summary of what it does. But basically, it's a plicating device that has 2 nitinol anchors that are brought together. So it's not actually true suturing. It's just bringing 2 pledgets together connected by suture. All right, and that's what it looks like afterwards. So you're just sort of plicating down the stomach. All right, so this was a 4-center trial, 2 surgeons and 2 gastroenterologists, 25 in the treatment group, 10 in the control arm, BMI of 35 to 40, a 12-month study, and the control was intensive lifestyle management. Primary endpoint was total body weight loss. If you look at the results here, so comparing the two, so in the POSE group, total body weight loss was about 15%, procedure time under an hour, average of 20 plications, quite well tolerated, no significant adverse events as well, and that was significantly better than the control arm. All patients got an EGD and an upper GI series at 12 months, which was great in terms of rigor, but this is what it looks like, similar to that previous picture I showed you all. And then you can see it's sort of the pledgets here where the contrast is not being uptaken. So everything basically held up. And in my opinion, this is probably the most robust gastric plicating device that we have available to us, and that seems like it's borne out in the trial. All right, so our next abstract is a very interesting one. So this is clinical outcomes of 3 different techniques of endoscopic gastroplasty results at 18 months, follow-up from a single center RCT. It's a very rigorous trial. This is a single center, 3 arms, and then a control group. So one group got the ESG using the overstitch. One got vertical gastroplasty, but essentially an ESG using an endomena device, which I'll describe in a later abstract, but another plicating device. And then one group got the POSE 2, which I just described to you in that last abstract. And then the control group got a low-calorie diet. And importantly, no anti-obesity drugs were prescribed during the trial, which is always key in our field. Just to walk you through, you can ignore the top of the slide, but basically at the bottom, 240 patients, 60 were assigned to each group, Apollo overstitch, Endomina, pose 2, and then 60 in the control group. And then looking at the results at 18 months, total body weight loss, excess weight loss, but you can see between the groups, basically all were the same. So any way you placate the stomach, you get about a 14 to 15% total body weight loss, significantly better than the control group. I like this abstract because, again, it shows the fact that if you can get robust plications, any way you do it, you're going to get weight loss. Technical success of 100%, 1% rate of serious adverse events. That mirrors what we've seen in previous trials of devices. Comorbidities all improved, as well as quality of life in the intervention groups. All right. Okay, next abstract. This is on that Endomina device, just got 510(k) clearance here in the US. This is the first US experience using a novel endoscopic gastric plication device for the treatment of obesity from the Brigham group. But this is a device actually you assemble. So you pass it into the stomach and then you assemble it onto the gastroscope once you're in the stomach. And it gives you quite robust plications in the stomach. So it's approved for tissue plication basically in the stomach, but an obesity device. So a single center retrospective study, 55 patients, technical success in all but one of them. And they basically used 9 plications in a belt and suspender pattern as I described in that first pose 2 abstract. This is what it looks like. So you might be hard to see in the back, but these clear arms of the device sort of reaching out over the end of your endoscope. And then you're passing basically sutures through that. And that's what it looks like afterwards, quite robust in terms of the tissue plication effect. In terms of results, total body weight loss of 15% at 6 months, 16% at 12 months, and 90% of the patients achieved at least 10% total body weight loss. Okay, so you've seen a bunch of plication abstracts, and you're noticing now on the back of the MERIT trial, all of these newer trials and all these newer devices, we're starting to see consistency in terms of what we're getting with gastric plication endoscopically, around a 15% total body weight loss, 1 to 2% rate of adverse events. So I think in 2024, we're here, and that's basically what we have. Okay, this was an interesting one. So this is the impact of baseline gastric emptying times on long-term weight loss following ESG. So the way ESG works, if you recall, is that it actually delays gastric emptying. So surgical sleeve speeds up gastric emptying, endoscopic sleeve slows gastric emptying. You have that fundic cap and things basically stay in there almost like an ice cream cone shape. So food stays at the fundus, maybe activating stretch receptors and suppressing ghrelin, we're not sure, but it delays gastric emptying. So the question is, how would baseline gastric emptying affect your outcomes after an ESG? So this is 24 patients, baseline gastric emptying test and ESG, single center retrospective chart review. So basically they divided them into 2 groups. So those with a rapid gastric emptying and those with a slow gastric emptying. And those with rapid gastric emptying actually had significantly greater weight loss at 6 months, which would make intuitive sense, but an interesting study to prove that. So if we can delay their gastric emptying, they'll have better weight loss outcomes. So again, maybe this is a way for us to select patients. And again, faster pre-op gastric emptying time, significantly associated with greater weight loss at 12 months. Next abstract. So this is the effectiveness of ESG alone versus ESG plus APC afterwards, a prospective longitudinal study. The thinking here is, okay, we use the overstitch, we put in some sutures into the stomach, proline stitches. How can we improve the durability of these stitches? And one way is to prepare the tissue. So basically ablate the tissue and maybe that'll induce scarring after you put in those stitches. So prospective study, 95 patients, 71 got ESG and then 24 later got ESG plus APC, followed them up to 12 years. Primary outcome was total body weight loss. So the interesting thing here actually is that in the ESG group, they actually had higher rates of weight loss with ESG alone versus ESG plus APC. So it's kind of counterintuitive. So if you try to enhance the ESG by adding some APC, they actually didn't lose more weight. In fact, they lost less early on. So interestingly, ESG alone actually had better weight loss than the addition of APC after you put in the sutures. Now, there is a big confounding in this study in that a lot of these patients were on anti-obesity medications as well. So this data set is actually muddy, and this is data set that they had pulled from other trials. So I don't fully buy it yet, but it's sort of interesting. The other caution when we do APC after we suture is that you can actually cut the suture with your APC. So who knows if that happened as well. So I think the jury's still out on this, and maybe we need to do APC beforehand and then suture. Who knows? But interesting negative study. This one is fascinating. Endoscopic ablation of the gastric fundus in adults with obesity, a first-in-human study. So the idea here, again, is that we're going to target the fundus and ablate the ghrelin-producing cells. Maybe we can alter satiety that way. So no tissue plication, no volume reduction. We're just going to ablate the stomach. So very interesting. So in this study, they're using the hybrid APC, and if you're not familiar, it's an APC probe that actually does a submucosal injection at the same time to increase the safety of your APC. So you get this sort of bubble, and then you can ablate. Okay, so they're using hybrid APC, pilot study, 10 patients. They did an EGD at 6 months, and it's pretty interesting when you look at this view. So this is baseline, you basically ablate it. You can clearly see the scar here with the loss of the rugal folds. So there's certainly an effect. And their primary outcome is change in fasting plasma ghrelin at baseline and at 6 months. So you can see it graphically. So ghrelin does significantly drop at 6 months and maintain the drop. This is maximum tolerated volume. So it's basically a measurement of satiety in terms of your volume of intake that you can tolerate. And that's decreased over 6 months. So 50% decrease in ghrelin levels at 6 months, which was significant. Around a 6% total body weight loss, so pretty modest, but again, we're not doing any sort of volume reduction in the stomach. We're just ablating the fundus. And decrease in mean hunger scores as well, and no significant adverse events. So there is another trial now that's actually looking at a total ablation, basically, of the stomach. So they're going to be ablating the fundus as well as the body of the stomach. So that's something to look forward to as well. Maybe next year we'll talk about that. Okay, next abstract. So the efficacy of revisional ESG alone versus revisional ESG plus GLP-1 analog for weight regain following sleeve gastrectomy. So again, so that we're doing basically an endoscopic sleeve within a surgical sleeve when we're trying to achieve greater weight loss. A retrospective study of 80 patients. I'll cut to the chase. So basically, at 12 months, combination therapy with endoscopic sleeve plus GLP-1 analog had a better outcome than revisional ESG alone. So combination therapy is going to achieve greater weight loss for our patients in this population. All right, last obesity abstract, transoral outward reduction with endoscopic submucosal dissection versus APC, impact of tissue prep on weight loss in patients with Roux-en-Y gastric bypass. So transoral outward reduction is basically our endoscopic revision of gastric bypass. We suture around the gastric outlet and reduce that almost like an iris as an aperture to enhance restriction. This has been around for a long time. We've done it, it works. But this is adding the element of ESD. So we're basically going around the outlet of the pouch, and we're cutting with a knife to expose the submucosa and muscle and then suturing it. And we think that may enhance outcomes that way. And again, bottom line, ESD TOR is better than standard TOR, but you do get a higher rate of stenoses, so a 10% rate of stenosis where you actually have to go back and dilate, but you do get enhanced weight loss outcomes with the ESD approach and no significant adverse events. All right, moving on. So now we're going to move on to resection abstracts, a couple of important trials that we need to cover. Okay, so the first one is cold snare endoscopic resection for large colon polyps, a randomized trial. This was led by Heiko Pohl, a multi-center US trial, comparing the safety and efficacy of cold and hot EMR for polyps greater than or equal to 20 millimeters. So cold versus hot EMR randomized trial. 15 centers across the US and Canada, 660 patients were randomized. There was crossover at the discretion of the endoscopist. About 15% of the patients crossed over into each arm at their discretion. Bottom line in terms of the outcome. So looking at polyp recurrence at first follow-up, cold EMR is in blue, hot in red. So there was a higher rate of recurrence at first follow-up, almost 30% in the cold EMR group, but 14% also in the hot EMR group in the intention to treat arm. And then if you look at significant adverse events, a low rate of adverse events in per protocol and intention to treat in the cold EMR group, and then a rate of 4 to 5% in the hot EMR group. So they concluded There's no clear safety benefit to universal cold EMR, but if you can do it, it's safer. There's a high recurrence rate after cold EMR, as well as a high recurrence rate after hot EMR. So I don't know if you audit your own EMR recurrence rates in your practice, but these are really high numbers that we see here. And these are from expert centers across the US. So it makes you wonder, why are the rates so high in both arms? We know cold EMR has a higher rate, but even in the hot EMR group, 14% is quite high. In my practice, I've audited when I was going to give this talk, and I have a rate of about 1% at first follow-up at 6 months. And there's nothing special about what I'm doing besides doing underwater EMR. So this is very, very high rates in both arms. So it's sort of interesting. So the next abstract is a similar trial, cold versus hot snare EMR for greater than 15 millimeter polyps, a randomized trial. About 90 in each arm. Primary outcome is residual at 6 months. Median lesion size was 30 millimeters. Technical success was high in both groups. So I'll just walk you through this. So about 90 patients in each arm, cold versus hot. If you look, and this is the cold EMR group, very low rate of adverse events, only 1% rate of delayed bleeding, no rates of perforation. In the hot EMR group, they had 7 patients with delayed bleeding, which was significantly higher than the cold group. Only 1 delayed perforation, but what they described as a 25% rate of deep mural injury, so muscular injury that they had to intervene upon, which is what we'd expect with hot EMR. But again, if you look at the recurrence rates, so in the cold EMR group, about 17 to 22%, much lower rates in the hot group, which is what we'd expect. Remember, I said about 1% rate. This is more real world, I would say, in terms of folks who are doing hot EMR. So again, lower rate of adverse events with cold EMR, but higher rates of recurrence at your first follow-up. So you can either look at this in one of 2 ways. Either cold EMR is a 2-stage procedure with a high rate of intervention on the second one, or you can look at it as a failure. It's up to you. But either way, these patients are getting 2 colonoscopies within 6 months anyway. So if you're being an optimist, you could say maybe it's a 2-stage procedure with a higher safety profile. All right, what about margin thermal ablation? So impact of margin thermal ablation after EMR of large non-pedunculated colon polyps and long-term recurrence. This is from Borg's group. So prospective study at 4 academic centers. So they got EMR plus margin thermal ablation. So what we'll do is we use the snare tip and used soft coagulation around the margin to hopefully decrease recurrence rates. And then they got their first surveillance colonoscopy, so that's SC1, first surveillance colonoscopy at 6 months, and then you're supposed to get your second 12 months after that 6-month colonoscopy, okay? So prospective study, 1,000 polyps underwent EMR. So we'll walk through. So 1,000 polyps underwent EMR, 775 were eligible for their first follow-up, okay? So 775 polyps got their first follow-up at around 6 months. They cleared the colon. So not only did they biopsy and examine that EMR site, but they also cleared the rest of the colon. So got rid of 34 additional flat polyps. So basically they had a 3% recurrence rate at that first follow-up. So quite low, which is good. Of the patients who had no recurrence, so you did your first surveillance colonoscopy, the site looks good. They came back 23 months later from there, and they only had 1 recurrence, and that was an IC valve polyp actually. So very low rates of recurrence if your first follow-up is negative, okay? So the thinking might be that, can we actually lengthen the next surveillance interval to 3 years? In other words, EMR, 6-month follow-up, if it's clear, next colon in 3 years. So this evidence sort of supports that approach, and that's what I'm doing in my practice at this point. Okay. So next one, looking at post-polypectomy bleeding. This is from our own Dean Jensen and colleagues at UCLA. So Doppler endoscopic probe blood flow monitoring and focal treatment prevent delayed post-polypectomy-induced ulcer hemorrhage in a randomized controlled trial. Multi-center trial, 174 patients. Patients were stratified by use of chronic antiplatelet or antithrombotic drugs. Standard treatment was basically following the ASG guidelines on anticoagulant management. And then this was Doppler endoscopic probe guided treatment. And basically, for those who don't know, it's a probe, it's an audible probe that you pass through the channel, and you can basically listen to a signal, almost like peripheral vascular flow checking on folks in their ankle. We're doing that through the scope into the defect, and if you can find a vessel, then target your clipping to that vessel. Basically, in terms of results, significantly less delayed post-polypectomy-induced ulcer bleeds in the Doppler group. And that was driven by major bleeds, so bleeding that required hospitalization and blood transfusion. So basically, if we can direct our therapy using the Doppler, we may actually save money by not using as many clips to close our defects, and we're actually decreasing rates of bleeding as well. All right, next abstract is about a novel starch-based polysaccharide submucosal injection solution results in decreased bleeding and adverse events in EMR and ESD. So this is a study examining basically EndoClot, which is a novel starch-based polysaccharide solution for an injection EMR. And they compared this to Eleview, which is our standard crystalloid oil emulsion solution, looking at outcomes from EMR and ESD. And this was a non-randomized trial. And their primary outcome is post-resection bleeding at 30 days. So basically across the board, if you look at the SPS group, which is the novel solution, there was less intraprocedural bleeding that required intervention, higher rates of en bloc resection, and less 30-day adverse events. If you stratify by polyp size, so this is less than 2 centimeters and greater than 2 centimeters, you can see this is really driven by the large polyp group, less bleeding in the procedure, more en bloc resection, and less 30-day adverse events. So that's interesting, because normally right now we're using submucosal injection solutions just to help us get the polyp out. But in fact, if these solutions are actually going to prevent bleeding and complications, now we're actually seeing solutions work for us. So that's very, very exciting to see, and we're going to see some more solutions coming down the pike, and it may be that these will actually help us out in terms of delaying complications for patients. All right, I think our last resection abstract is on EFTR, so endoscopic full thickness resection, available from Avesco. So this was entitled Medium-Term Oncological Outcomes Following Endoscopic Full Thickness Resection for T1 Colorectal Cancer, Results from the Dutch Prospective Colorectal EFTR Registry. So these were consecutive patients in the Dutch registry. They basically divided these cancers into superficial submucosal invasion, which is SM1, invading into SM1, and then deep invasion into SM2 or 3. These were the factors that they deemed that were high-risk features on these early cancers. They had a total of 556 patients that they included in this cohort. Skip that for time, but basically, R0 resection was achieved for 94% in the superficial submucosal invasion group and 90% basically in the deep submucosal invasion group, which is quite good. Recurrence rates were very low at 2% in the low risk and 6% in the high risk group. Excellent 3-year survival. And so their conclusion is that EFTR is an efficient first-line treatment for T1 cancers with a submucosal invasion less than 2 centimeters in size with low recurrence rates. So something to think about, again, in our practices for patients who may not be surgical candidates. All right, I'll finish up quickly with third space abstracts. I just have a couple here that we need to talk about. The first is about gastric peroral endoscopic myotomy, or GPOEM, is associated with long-term sustained clinical success and improved quality of life. This was a single center study from Indiana University, basically their own registry for 2 expert endoscopists. And they did baseline assessments. This PAGI-SIM score is basically a patient perception of their GI symptoms, GCSI, which is the gastroparesis index, and then their quality of life short form 36 score, gastric emptying scans, and endoflip. They did their GPOEM, had a rigorous follow-up algorithm following that. Okay, the only thing to highlight about the patients, 140 patients were included. Most of the patients, 66% actually had Botox therapy prior to it. Prior to their GPOEM, which is interesting, and I'll touch on that in a little bit. So if you look at their clinical responses, GCSI, so about half of patients will have a sustained response out to 5 years. And they defined response by a drop of their GCSI score by 1 point. That can vary between studies, but that's generally the consensus opinion on outcomes, is a drop in the GCSI by 1 point. So only about half of patients respond, but when they respond, they have sustained response. Okay, so we're still working on figuring out who's actually going to respond to these interventions. If you look at their PAGI-SIM score, basically the bottom line is that the score goes down, you feel better, and significantly across all time points, they felt better from a symptom standpoint, self-reported symptom standpoint. From the quality of life, the short form 36, when it goes up, you feel better, so it's better across the board, so they have sustained improvements in quality of life, even in the absence of clinical improvement. And this is the interesting thing. So in patients who have no clinical response, meaning their cardinal symptom index did not change, right? So this is at baseline and pink is at 6 months. They still had a small but significant improvement actually in their quality of life. So even if patients didn't show that they actually improved their GCSI, they still had improvement in quality of life, which may be another argument for us to actually intervene on these patients regardless. The other interesting thing to note from this trial, so looking at folks who had Botox as a therapeutic trial before versus non-responders, non-responders will get a response for about 3 months, which may just be a placebo effect. But those who actually respond to Botox and then you do a G-POEM, they have sustained response to at least 3 years. So this might be a reasonable test for our patients when you want to think about referring someone for a G-POEM, maybe doing a Botox injection, see how they respond. That may help us in terms of knowing who's going to respond ultimately to the G-POEM. All right, last abstract. So this is clinical outcomes of short versus long esophageal myotomy for idiopathic achalasia. So in our field, we've been doing, POEM now for over a decade. We do a relatively long myotomy, and the question is, can we shorten the myotomy and actually make the procedure faster and safer for patients? So this was a single center study, I believe, out of Wake Forest, including just type 1 and type 2 patients, because remember, type 3 achalasia, you do need a longer myotomy, so only type 1 and type 2 in this study. It was actually a retrospective study where they just personally started doing shorter myotomies, so it's basically a time control. So for the POEM, a short myotomy is considered 4 centimeters or less on the esophageal side, long was 7 centimeters or more on the esophageal side. They did a posterior approach. Clinical success was defined as an Eckhart less than or equal to 3. Pretty robust follow-up, 25 patients in the short, 25 in the long myotomy groups. And then bottom line is that mean procedure time was shorter in the short myotomy group, similar rate of adverse events, similar rates of clinical success. So basically, it was equally as effective and equally safe to do a short myotomy, 4 centimeters on the esophageal side. One question was regarding GERD, comparing the two myotomy lengths, and they're essentially equivalent, although there was a lower rate of reflux esophagitis in the short myotomy group, and the question is perhaps we're actually decreasing rates of reflux esophagitis if we go shorter with a myotomy. It's something that it wasn't powered to answer. I think that's it. So thank you very much for your attention, and we'll take questions after Adarsh talks.